Dr. Richards, good morning.
Good morning.
Another exciting football
Well,
weekend in Philadelphia. So hopefully this is our third podcast, I believe, and we've been 2 for 2 so far with good luck with the Eagles. So hopefully it's 3 for 3. Uh, but today we're going to, I think, talk about a pretty important topic, especially as a physical therapist. But for many people, we're talking about pain today, and pain is this thing that really is a dividing line sometimes between the idea of physical therapy and fitness, but it also can be, if well understood, we can use it to again blend those lines or blur those lines a little bit. So hopefully this is an important discussion. We're going to try to hit on 6 different categories around this. Hopefully we'll be able to do it in a succinct amount of time, but we'll give it a go. So the first thing I wanted to chat about with pain is just the differentiating the definition of pain from structural damage or injury. I'll have you take the lead on that and just see what your thought process is so far as a new grad in the PT world, but also just what you've experienced working as a trainer and then also with your own injuries as an athlete over the years.
Yeah, I think kind of this comes back pretty quickly to like the biopsychosocial model of pain versus the more pathoanatomical. In the traditional model, there's this idea that you have pain because something's broken and it needs to be fixed. But in reality, the research just is overwhelmingly showing that not every hurt equals harm. And we see this a lot in like chronic pain sometimes where we know low back pain is so prevalent worldwide, especially in the United States, and I think it's 80% of Americans experience it at some point in their lives. But really, the main predictor of if that back pain turns chronic is psychosocial factors, meaning it actually has nothing to do as much with the structural damage for the most part, if there even is any. So that's kind of where I come to. And that's, I think, a really important conversation to have with clients and patients, to actually help, especially of maybe the older generation where they grew up with that pathoanatomical model, to kind of help them change their perspective of what it means to be in pain versus what I would think of as an actual injury, would more so be kind of that damage, tissue damage, where there is something we need to address or something that needs to heal to a certain extent, but that doesn't always correlate perfectly to pain. And vice versa. Pain doesn't always correlate to damage.
Absolutely. And I think you can look at that from the other perspective, like you said, where there are a lot of injuries that we're very aware of, especially in like popular culture now because of sports, that are very obvious injuries because we see the mechanism happen before our eyes, right? Like you had 3 ACL tears, correct? Right?
Yep.
And you had to get surgeries. So the ACL tears are very obvious examples of injuries. And usually, if they're in sport, they're either traumatic or non-traumatic, but what happened in the moment, right? Like there was usually something that, okay,
Yep.
I heard a pop. That pop is typically the indication of an injury, but the dysfunction is not often pain in those situations, right? So you may get a little bit of pain early on, but the thing that's limiting you back to sport is not often pain. And you could tell me, your experience with it, but
Yeah.
that's certainly working with different clients over the years that have had these pretty obvious sports related injuries. It's not pain that is the limiting factor. It's a tissue healing process, and it's usually a feeling of instability, weakness, the inability to do something that you need to be able to do to get back to your sport. With that gets tied in apprehension and other things that we'll discuss that might actually enhance pain or decrease pain depending on what the psychological state of the athlete is. But we oftentimes will look at that injury, that obvious injury, or you can look at a baseball pitcher that like their elbow goes on one pitch. There's an injury there, but we assume then it's pain that's the limiting factor to get them back to sport. And oftentimes that's not the case. It might be part of it, but it's rarely the major factor there. Where when we see people in a clinic that are in a chronic pain state, we tend to reverse that in our minds. We're saying, okay, well, there's all this pain that people are coming in. There must be some type of underlying damage, just like the injuries we see on TV with athletes. And there's a big discrepancy there. And I think that's the important thing for most physical therapists. You're not going to be seeing people acutely right after an injury. And if you're working with athletes, you'll see a lot of injuries that need to go through a healing protocol. However, for the general population of people, it's oftentimes pain comes on from what's called an insidious onset, where there isn't an obvious mechanism of injury. It could be, we could think of it as overuse to something, and that's usually involved, but it becomes a bit more complex now because we do have to take in these other factors of the psychology of the individual, the social factors. You know, what is this pain getting in the way of them doing their job? Does it lead to changes in their life? Is there a comparison they're making to other people in their life there? Is it something that, you know, psychologically you don't love what you're doing, and this pain is actually making you not have to do the thing you don't like doing as much, right? Yeah. And none of this stuff is overt, meaning it's oftentimes not an obvious thing for the person. Like people aren't malingering, which I think used to be the way of thinking about this. Like if somebody's pain didn't fit with their structural damage on an MRI or an X-ray, we used to think of those people as malingerers, right? That was the terminology, and it's still sometimes used, but I think we've gone past that now to realize that the problem is that pain was never, that chronic pain state was never the damage, right? So if we have these assessments to look at quote unquote malingering, we're not understanding pain in the first place, right? So it's sometimes this idea of the biopsychosocial model gets painted as we're trying to say it's all in your head to a patient, or we're not really taking into account the experience of the individual, or it's actually quite the opposite. We're not discounting that their pain, but we're saying it's more than just what an X-ray or an MRI. And if you're in that constant search for that exact answer, you're barking up the wrong tree. We need to do more. There is absolute pain that you're experiencing, but we need to understand it from a much broader perspective.
100%. And actually, like, it's interesting you talk about the imaging part as well, because, you know, we know now that imaging doesn't really have much correlation to the physical symptoms we'll see. Right. And that's pretty heavily backed up by research. But like, interestingly, there's been a couple studies coming out with patients with chronic pain, and they'll do actually MRIs, fMRIs of their brains. And actually they do see like these significant changes in the brain's response to certain signals, which I just find is interesting, because it's like, well, not only does imaging not necessarily correlate to symptoms, but maybe also if you want to take an image, you don't need to be imaging the back. If someone has back pain, maybe you need to look at what's happening more centrally. Yeah. And those are really the long-term changes that occur with those people in chronic pain.
I think that's a great point. And, you know, that what you're alluding to is there's a ton of studies that will look at MRIs and X-rays of people that have no pain whatsoever. And the numbers are pretty overwhelming, 80%, 70% at least, of people that have these quote unquote damages in their body, these what would be looked at as injuries if there was pain present, and they're completely pain-free. So you start to get the idea of, are these changes internally just more natural processes of aging, or just normal changes over time, if there's really no good association to someone's pain in the moment? And then on the other side, there's definitely studies where people that are actually in pain, they will get imaging, and there's not really an association to the severity of the quote unquote damage that's seen in that imaging. But the other thing is we're sort of limiting our idea of structural imaging and structural change when we're just looking at joints, muscles with MRIs and X-rays, and we're not appreciating the changes that happen within the nervous system, which is at a much more micro level, right? So it's harder to assess those things, and those in the nervous system is much more plastic, so it's ever changing, it's more dynamic, which is awesome when you actually want to change for the better. But we have to appreciate that it might be not as obvious or specific from a diagnostic standpoint to talk about the structural changes that are happening within the nervous system. So we have to be okay with that. We have to be able to be in a process And then this is where things like a movement continuum or just physical therapy in general, we're more process-oriented professionals, that we're looking at how somebody's presenting in the moment every day. And we're trying to like really take into account how they feel about what we're having them do. Like, so their belief system, what they feel is safe really matters, not just some idea of an X-ray or an MRI telling us what to do. Right. So that's, I think, really important. But to get back to the idea of nervous system changes, like, so you can look at functional MRIs now and see what's happening in the brain, which is, the brain's obviously the motherboard of the nervous system. That really matters. But then we can even look at any receptors within the body, right? And there's a ton of little receptors that just basically respond to stimuli. They respond to pressure. They respond to heat. They respond to movement, to stretch, right? So we have all of these mechanoreceptors, thermoreceptors. All of that is changing and responding to a stimuli, and that can be looked at as something that needs to change in a specific way to get someone out of pain. So we can call that desensitization, right? And there's so many different ways that we're already using different tools to try to desensitize, but I don't think we put it in a broad enough category a lot of times, right? So we were talking about this the other day, the idea of the TENS unit or the electrical stimulation, so popular in physical therapy. We know that it's valuable in some cases, but we know that it's not really going to change things permanently. But what it is doing is creating, it's part of the process of desensitization for some people, right? So the tricky thing when we're talking about changing the nervous system or changing a receptor's response to stimuli is it's very independent of the person and how they feel about the stimulus that you're giving them, right? So some people really love deep pressure, which would have a change to the mechanoreceptors, the pressure receptors. But if somebody thinks of that deep pressure as threatening and they don't like it, they're going to have a totally different response within their nervous system, right? So we have to really make it person independent to figure out what somebody thinks is safe. But what we're actually doing is changing the physiology of the body. But so it's, I think sometimes when people hear psychosocial, they start to think, well, it's all in my head, not appreciating that your head is part of your nervous system, is part of the physiological changes and the structural changes that happen within your body all the time. It's just a little bit more plastic than what we were taught when it's about joints. You know, if you have arthritis, well, you can't make that better, right? There's no healing process to an arthritic joint. So after a while, you're just going to need surgery, which is false information, but that's actually what's being peddled.
Yeah, absolutely. And I think, like, you know, kind of coming a little bit to, I guess, talking about like that, giving them that experience with movement and that we're actually trying to change the physiology comes back to, you know, if someone, like, ultimately as physical therapists, I think one of our biggest goals is to help people find a positive relationship with movement in a really sustainable way, especially in our kind of hybrid setting. And that really comes down to, like, yeah, you do need to address some of these central factors, but you can do it in part through movement and then talking through the things that you're seeing, that they're experiencing as they go through it, and then gradually change their thoughts and beliefs so that, you know, a lot of times we get people that come to us in chronic pain that are maybe sometimes scared of even going on a walk down the block or scared of any type of physical activity, and not realizing that that's actually just exacerbating their condition to a certain extent, where their whole physiology and their whole ability to tolerate stress has just decreased significantly. So helping them find that positive relationship with movement is not only going to be helpful for their pain, but also it's going to be really helpful for their overall health and wellness as they age and grow older.
Absolutely. And I think we've talked about this before, like the more chronic conditions are, what the research tends to show is the most useful is actually really broad general things, right? Like getting more fit, you know, so, and fit, not just from a movement standpoint, but from a health and behavior standpoint too. So get better sleep, eat better, right? And, you know, better in this case, I'm just trying to be very vague, but that has a whole assessment process to it that could be unique to the individual. Be able to move better, be able to tolerate more things, right? Because you're trying to change all the systems in your body pretty much, right? It's not just the musculoskeletal system. You have to change like how the nervous system responds to things, which actually changes the immune system, right? So all of those things are always intertwined. So the more broad our interventions, a lot of times we're able to work and help more systems. So that's really important. And that kind of brings us to the topic of looking at, like, when we talk about the biopsychosocial model, there's research behind that, but then there's categorizations or subcategories of things that tend to get looked at with that. So 3 things that get studied a lot are pain and somebody's fear or willingness to avoid, or tendency to avoid movement because of pain. And then that goes hand in hand with self-efficacy, which is somebody's belief that they can actually get better. And then really closely tied to that is the locus of control with somebody's belief system. Do they, if you have an internal locus of control, you feel like you're in control of your own change, or if you have an external locus of control, you feel like somebody else needs to fix you. So all of these things really get studied well, and especially self-efficacy and what if you have more of an internal locus of control. So if those things are higher, you see better prognosis across the line with people who are in a pain state. What's interesting to me is the idea of fear. That hasn't been as well associated, even though we see that in the clinic. Like, fear usually is a sign that, okay, this is going to be a much slower process, and we're going to have to kind of work with people through that. But it seems like over the long term, it's more like self-efficacy. Just having some belief that you can change yourself is more important than fear, because I think fear can be changed over time just by having the right person educate you, or just being in the right situation and sort of disproving your initial fears. I think that can change pretty quickly. So it's been interesting to me to read some of the newer research that seems to separate out fear avoidance as this like super negative. And it really depends on how much is there and how ingrained it is. But it's more important that the individual, the patient, feels like they're in control of their own change, or they have some control over their own change, which I think is pretty interesting.
Yeah, it really is. I think like the fear part that you hit on is so crucial to talk about too, because really, if we think about pain to a certain extent, like, it's really a danger signal that our brain is sending out, that whatever we're experiencing isn't safe. Whether that's a physical trigger, or sometimes, especially with people who are experiencing chronic symptoms, sometimes it can almost be a psychological or environmental trigger. I've had people in the past where it's like their pain gets worse when they're walking to work.
Yeah.
Because they're stressed out about work. So that's where what you hit on, just finding the right person who can educate you about that and kind of walk you down that road, is going to be really big for the long term. But the research really is overwhelmingly pointing to the fact that self-efficacy plays a massive role in your ability to get better. And internal versus external locus of control, I think it's in a world sometimes where if you have been down the chronic pain route and you've seen multiple doctors, seen multiple practitioners, it can start to feel like things are kind of out of your control, because things just don't seem to maybe be getting better. So finding even a glimpse of that, just something you can do that feels like you're able to take back control as a patient or someone experiencing chronic pain, can totally change the trajectory of your recovery or prognosis.
So, and practically as a movement professional, like, what you'll start to need to change or listen for is language around this idea of like a growth mindset versus a fixed mindset. So, and you'll start to notice this more as you're paying attention to it, where there is just certain individuals that feel like progress is kind of fixed. People are good at things because they were born good at things. They're naturally smart, they're naturally attractive, they're naturally fit, right? And then there'll be another mentality that's, okay, you have to work for everything, right? Or you get to be at a certain place through your efforts, right? So we have to be careful with, our language, but listening for this type of growth or this fixed mindset language and trying to gradually over time veer it more towards a growth mindset, I think is a big part of what we have to do as movement professionals. And certainly not something that I learned in school or was taught that was important in school, but I think it's probably one of the most important things to do as a movement professional is to gradually, not with heavy hands, and I've learned that the hard way sometimes, because I often notice that I'll actually get triggered, if we'll use that terminology, by some fixed mindset terminology, and then I can be more harsh than I would like to be with trying to get people away from that. But it is an important conversation to have gradually and be patient with your patients and clients over time. And that's why you need time with your individual, I think, a lot of times too, because that's not an easy thing to change, but it's a really important thing, knowing the science behind what's our job is to try to get people out of pain. Well, how do we do that? We have to follow the science. The science is now saying that self-efficacy and getting people to believe that they can make change, positive change, and be in control of that is important. Well, how do we become part of that? Well, one is really listening to their language and trying to guide them down the path of more internal locus of control. And I think the other part of that is the next thing to talk about with pain is, from a movement perspective, to put pain in a perspective with the movements that we're doing, especially for our job. We're always getting to see people move, that we can break down where their onset of pain is within a movement, and we can start to categorize out like what their pain is, and give them a little bit more information about what we see as, okay, the pain comes on here, but look at all the other things that it doesn't come on with, right? So, and what does this indicate about what we have to do, right? So now all of a sudden just getting some more information about the pain, and not just being, it hurts broadly and it's painful every time I do this. We have to know a little bit more specificity about how the pain presents within particular movements. And that often gives more control to the individual, because now they can view it in a spectrum of what they can and can't do, or what they're ready for and what they're not ready for, which starts to change it to like, okay, I have to just wait until this gets better so I can get back to doing what I was doing before. Instead, it's like, okay, I have to be more cautious here, but I could be less cautious here, right? So now I have a little bit more control of the situation. I don't have to play this waiting game. I could still be fit, work on my fitness. I just have to be a little bit more cautious around the very specific corners of where my symptoms are provoked.
Yeah. And really, like, the onset identification that you're talking about, I think, is crucial too, in the fact that, like, pain sometimes it's unknown. Like, it's just things we don't fully understand, and really being better able to understand what brings it on, what kind of turns it down, at what point in movement it comes on, or at rest, is a way to actually kind of make it more known and more comfortable psychologically as well, which can probably decrease that fear response that we often see. But, I know, talking about onset identification, you kind of have a way that you like to categorize pain when you're taking patients or clients through movements. Would love to hear you talk more about that.
So, well, I'm going to discuss this generally right now, and just kind of, I have a little bit of like a ranking system in my head for what I like to prioritize, but I think it's good if we do like a full episode on really deconstructing all of these topics, because this could be quite useful, and it'll be a little time consuming. But generally, like, I'll look at 11 different things, and that doesn't mean I'm frequently doing all 11. But just to have a sense of, if you have the person that is really the most sensitive to pain you could possibly think of, sometimes you can't even move them, and their symptoms are provoked with just even the idea of movement, right? So, number one would be the idea of graded motor imagery, which you could really break that down into actually having people imagine movements. You can have somebody move with their non-dominant side in a mirror, which makes them think that it makes them appear in the mirror that they're actually moving the side that's painful. So then you're sort of playing with the nervous system, the brain, a little bit, to get people to start moving, but have them associate movement in the side that is typically painful by moving the non-painful side. And then there's actual apps that you can use for left-right discrimination, right? So just having people look at pictures of bodies and separating out, is this a right side? Is this a left side? A lot of times you'll see, when people are in chronic pain longer, there's evidence that they're yet much worse at being able to discriminate left versus right. So it's almost like you're working on someone's proprioception before you have them move, or their position sense, different coordination. You can think of all of those things, but it's pre-movement. So if someone's really in a bad way where everything hurts, like, and you're surprised how little movements will flare things up, then graded motor imagery is a good start. Can't say I do it a ton in the clinic, but there are times where I've had people use some apps to look at left-right discrimination while I'm getting them do very gentle movement. And it is interesting to see, how poor some of the results are at first, and that they can get better. And there's no movement at all, but it just becomes a mental task. So that would be number one. And we definitely dive deeper into that topic in another episode. Two would be pressure application. So and all this is graded. So if we look at things like foam rollers and massage balls, instead of thinking of them as, well, we're trying to loosen up a muscle or tenderize a muscle or, create some type of pain to the area, what I like to think of that as is we're trying to get the body gradually more tolerant to pressure. So we need to have a lot of different options to add pressure into the mix. So there's going to be a difference between using a piece of metal and a piece of really soft foam, right? And we want to think of that just like we think about adding weight to exercise. Is like we're going from progressively lighter to progressively heavier. Well, more density of pressure should theoretically be more threatening to the nervous system than less density. So if we can gradually add more pressure and then try to, within that, find someone's threat response, maybe find the symptom, but it can also just be like, okay, I can't be here. I can't spend a minute, 2 minutes here. It's too much. So let's find something that's a little bit less intense, and trying to play that game and have that assessment of what is the amount of pressure that is tolerable for you right now. That goes hand in hand with manual therapy a lot of times. That's what's being assessed with direct mobilizations to areas that are sensitive and tender. We're going through some type of process of, am I going into the resistance of the tissue, or am I going beyond it? Am I trying to create mobility with my mobilizations, or am I just trying to relax the area? I mean, there's all different ways to think about it, but the idea is we are gradually applying pressure to the body, and we're stopping at the individual's onset of pain. So that would be the second one before we really get people moving actively. And then we'll look at graded active motion, right? Just getting people moving without resistance, but on their own. And then it would be, you could tie that into passive motion, where somebody's moving you maybe farther in a range of motion than you can move yourself, assessing the relationship there. And these aren't in a perfect order, but it'd just be like, again, a checklist. We're trying to hit all these boxes. And then from there, we can add some isometric resistance, or now this would be the first time that we're looking at adding a little bit of resistance to the movement, not just movement without resistance. But we're doing that without actually moving the joint through a range of motion. So we're adding resistance at different parts of the range of motion that we can have more time to see if are safe or not. And then the last several are basically going to be tying into what we're talking about with position and transitions, how to add challenge to that. So we'll have different ways to support a position, and adding supported positional challenges, supported transitional challenges. So we're supporting or assisting a transition using maybe the upper body to support a lower body movement. And then we'll go unsupported with both the position and transition. And then finally, we're adding external resistance to positions, right? So we're adding weights to some of the things that we've looked at that were safe and pain-free when they were unsupported. So that's basically the way that I'm looking at it in the head. And sometimes you could do that all in one session, right? Very rarely would I say in my clinical experience do I have to use some of the graded motor imagery stuff, but it's nice to know you can always backtrack to pre-movement if you really needed to with somebody that's really in a bad state. But to have this be a spectrum, a sliding scale in your head, that you don't have to touch all of those, but saying like, I could if I needed to, right? That there is this really, really gradual spectrum, and I can go really hard. I can really intensify things by just making it a resisted assessment. If somebody's like not in that sensitive a situation, but more towards athletic goals, or they have very specific pain with resistance, sometimes you need to load it. So you need to have that ability to assess the onset of pain from the very minimal amount of movement or even pre-movement to intense movement. So that's sort of the idea there.
I really like the graded motor imagery piece, just that it's literally the first thing you could probably do with someone.
Yeah.
Like just think about doing something. And that's really like your kind of, if you do have someone who's incredibly sensitive, that's kind of where you'll eventually possibly go to if you need to go to pre-movement.
Yeah, and sometimes that's just a matter of getting a little bit of buy-in with having people use apps and doing things that seem weird. But if you're in a situation where someone's afraid of movement, or and they really get sensitized by any thought of movement, it could be a really useful thing. And sometimes it's just as simple as, here, play with my phone a little bit, play with this app. And it's like playing a video game with some of these things, and you can just have another assessment that at least keeps you in some type of process moving forward.
I really like that.
All right, so I think we'll pick up. I want to do a part 2 of this because pain is a really important topic. I think we talked about some good things, but I want to do this topic justice by allowing us to talk a little deeper on some of these things. We still want to get to the idea of red flags and scope of practice with pain. All right, because pain's a serious thing. It can be a serious thing. So we need to make sure we're discussing the idea of ruling out really sinister things. And I just want to make sure we do that justice, and also talk about scope of practice, right? Like, so if you're in a profession where you're able to treat pain, know the difference there between being in a profession that's not. But everybody should really have an understanding of pain if you're working with people, I think, but you have to also know when to refer out. So I think that's an important discussion, and I don't want to rush it.
Sounds good.
All right, so go Birds. Hopefully next time we talk, we're Super Bowl champions.
Let's hope.
I'll see you next week.
All right, see you.